So we've looked at other ways. We've looked at deviations from national standards. Now, the children in child welfare are particularly fortunate because they actually have national procedural guidelines that govern care for them, that basically say how you ought to be structuring and delivering care for these children. And these practice guidelines have been established by the American Academy of Pediatrics, by the American Academy of Child and Adolescent Psychiatry, and the Child Welfare League of America. And they're all very, very consistent. And we've done some prior publications where we operationalized and showed this at a national level. In this particular study, we actually wanted to check to what extent are children receiving care consistent with these national guidelines. And it turns out that by wave 4, and these are cumulative percentages, so if you look at any national standard, only a little over 50% of these children are actually receiving care consistent with any one of these national standards. And if you look at the screening metric, which technically everybody should actually receive, less than 50% are actually receiving screening for mental health services. And if you look at assessment and referral to services, now if screening is over here and referral is over here, if screening were up there, referral would probably also be up there somewhere. And the gap between where referral ought to be and where referral actually is actually a magnitude of our ability to underestimate mental illness among this population. It's a measure of unmet recognized need among this population. And this is particularly worrisome. Because if you don't assess, if you don't screen everyone, you actually won't know that these kids actually require services. And so we've talked about in our papers and other work, derivative work, we've actually talked about how we badly need to raise screening and assessment strategies among this population. I can tell you something more about that in the Q&A. A third way to look at quality is by looking at geographic variations. And mental health services are a very, very attractive way of looking at these because mental illness does not cluster. It's not like cancer. If you live near a pollutant spewing area, you're probably likely to have a higher incidence of cancer as opposed to if you were to live in a lovely place that did not have access to any environmental pollutants, right? So cancers cluster, and in fact that's how we know that there is a carcinogen in the atmosphere when you look at clumps of people who have cancer. Mental illness is not like that. There is nothing that causes mental disease to cluster. And therefore, if you see a clustering of treatment, it's likely that those clusters actually reflect changes in practice patterns as opposed to changes in the underlying distributions of the disease. And so that is why mental illness is so interesting to study from a variations perspective. And so Gyanesh and we have looked at this. These are the 8 states that have the largest child welfare populations in the United States. The best state to be in, or the worst, depending upon your perspective, if you don't like meds, is actually New York. New York is the state that has the lowest adjusted probability of medication use among their particular child welfare samples. The state that has the highest probability of adjusted probability of medication use is actually Texas. And the difference between New York and Texas is about 7-fold. And so controlling for everything else, if the fact that you live in Texas gives you a 700% increase in the probability that you will actually be medicated. And what we were interested in knowing is seeing if we can try and look at these interstate variations. And so these, I have to thank Gyanesh for the fancy graphics on this, which completely surpass my abilities with PowerPoint. So these are the same states that I showed you on the previous graph. And this is the same adjusted probability of medication use. And so what I'm trying to do is I'm trying to see if I can make all of these variations become flat. In other words, if I can make all of these bar charts the same, and that way I can tell you that I've explained away this variation that we're seeing between states. And so if I add in child demographic characteristics, demographic characteristics, I still don't manage to take those variations away. If I control for child need, that still doesn't do that good of a job in eliminating or explaining these variations. If I add in caregiver and caseworker characteristics, that decline sort of moderates somewhat, but it still is extant. But if I add in health policy characteristics, you see that these variations actually expand dramatically. And by policy characteristics, I'm primarily talking about Medicaid policy characteristics, such as how a service is paid for, is it a traditional fee-for-service system, are they capitated, are they doing managed care, and how are provider systems structured, are they doing behavioral carve-outs. And finally, if I add in health resources, like the proportion of psychiatrists, proportion of pediatricians, proportion of hospital beds available, we see that we've actually dramatically increased the interstate variability in adjusted probability of medication use. And we've done derivative work using Bart Hamilton actually taught us how to do the Blinder-Wahaga decomposition, and we did studies there which actually suggest that the problem doesn't so much lie in child need, but actually lies in the system. That it's primarily how the system evaluates the child that is the culprit. And we have our paper actually talks about how the way in which care is structured and organized in Texas is very, very different from the way in which care is structured and organized in New York. And those changes actually cause these variations, which cannot be explained by child need or by child socio-demographic characteristics. I'd like to do the last part of my talk by focusing on these two studies that we've just gotten, that we are on the cusp of getting funding for. This R01 study from ARC did actually very well. It got a second percentile during review. We're very happy about that. And it primarily looks at how can we do a better job of predicting Medicaid expenditures among children and child welfare. And this other study that looks at race ethnic disparities actually also did very well. It got an 11th percentile and was approved, and we're waiting on that. This talks about race ethnic disparities and how do Medicaid policies contribute to race ethnic disparities in care. And in some ways, this study and this study could be thought of as sort of fitting into one another. You could think of this as the cause, as if we don't manage our expenditures for this high need, high use population adequately, really bad things will happen. And one example of a bad thing that will happen are race ethnic disparities, which are in fact, when you think about it, completely paradoxical. We have a population that has entitlements to Medicaid. They have caseworkers, they have caregivers, they actually have an entire support system that is designed to get them into care. And still, we're seeing race ethnic disparities in care, which is deeply worrisome. And we argue that the reason why you're seeing this is because we haven't done a good job of doing this. And so those two really link together, at least in my mind, in that way. So let me show you some. So this is what we've been doing over the past 3.5 years or so. The National Survey of Child and Adolescent Wellbeing has a large group of youth who actually have social security numbers. And so we obtained Medicaid Analytic Extract, which is basically Medicaid claims files from the Centers for Medicare and Medicaid Services for the years 2000 to 2003 from 14 different states. Actually, this is up now to 16 different states. And once we bought those, we then began the process of securing permissions to link these two together. And I was absolutely naive in how long I thought that this would take. I thought this would take 1.5 years. It actually took us 3 years to do. It took Centers for Medicare and Medicaid Services, CMS. It actually took us a long time to go through CMS's approval processes, especially because we wanted social security numbers of these Medicaid beneficiaries, and they couldn't separate out the child welfare kids. And they simply gave us a data dump of all Medicaid beneficiaries for those years from those 16 states with SSNs. And so we had to go through a huge approvals process and data security plan and all sorts of stuff. And then we had to get permission from the Administration for Children and Families, who were the federal agency that actually launched the National Survey of Child and Adolescent Wellbeing, because we wanted social security numbers of these kids, and that which is what they controlled. And so we sort of had another go round about why we need them and how we promised that we'd be really careful with them, so on and so forth. We then needed ResDAC to figure out a way for us to develop unique research identifiers that would link these data. We had to get approvals from the NSCOG group within RTI, which originally fielded this survey and possesses the actual names and identifying information of these kids. And so we created a Chinese wall, is that what it's called? Where we, even as principal investigator, I don't know who these kids are. I have no access to social security numbers. Only these people do. And so they link those and they give it to us. And then we create our own unique identifiers. So there is absolutely no way I can know who these kids are and identifying information. And then we had to go through RTI IRB and then Washington University IRB. So all of this took about 3.5 years to do. And we then needed some money from the CDC in order to do some proof of concept studies. Because we needed some preliminary studies to write our R01s, and to say, trust us, we will do this, was insufficient. So it took a little bit of time to get some money. We got some preliminary Medicaid data, and we then linked survey data with claims data. Very briefly, this is how we did it. We linked all NSCOG kids to the Medicaid personal summary file or the PS file using their SSNs. We linked it to claims data, we aggregated it by beneficiary. We developed a comparison sample of Medicaid beneficiaries who did not seem to have child welfare involvement in order to look at what the difference in expenditures was between NSCOR kids and non-NSCOR kids. We dropped kids enrolled in Medicaid managed plans, and we had a final analytic sample of 52 child observations over 4 years. So, okay, good, some data. So these are our Medicaid differences. So this at the bottom are something known as the Medicaid RX. It's a classificatory system for drugs. It basically tells you what are the conditions for which these drugs have actually been used. So this is another way by which you can, because the Medicaid claims has information on the drugs, which per se is very hard to make sense of. And the red line are actually kids in the NSCOR sample, the National Survey of Child and Adolescent Wellbeing, and the ones in this ECRU are actually kids in our linked sample. So these are Medicaid beneficiaries who do not seem to have a child welfare involvement. And if you see here, there's a consistent pattern of Medicaid, of NSCOR beneficiaries using more, having greater expenditures for psychotropic drugs compared to linked sample, except over here when it comes to seizure disorders. And which you, when you think about it, probably makes sense, because anticonvulsants are used in the management of psychiatric illnesses, but they're primarily used in the management of neurological illnesses. And so this seizure disorder usage is probably for children who actually have actual seizure disorders, rather than anticonvulsants that are being used to manage childhood behavior problems. And overall, this is the difference, approximately a $700 difference aggregated over time over these populations, that marks the increase in expenditures that a child with a history of maltreatment incurs to Medicaid compared to another child who is poor but has not necessarily been maltreated. And in some sense, this difference represents the double jeopardy that maltreatment exerts upon children in poverty. So if you are a high-income kid, you probably don't have much mental health expenditure. But if you are a child in poverty, you have a marginal increase in mental health expenditures. And if you've been maltreated on top of that, there is an even greater marginal increase in your mental health expenditures. And that is what this is. And this is what we are failing to recognize, because Medicaid premiums are not risk adjusted. And so, because there isn't like a premium as such. And so now what we're doing is that, and so Missouri, for example, is going to roll out child behavior checklist, because we know that child behavior checklist scores are a dominant predictor of expenditures. And so we've managed to inform state policymaking in that way by decomposing some of these expenditures. Some more details on differences between NSCOR kids and comparative controls. NSCOR kids primarily have increased utilization on most of these therapeutic classes of drugs. We also did a two-part expenditure model, and it actually shows that, so there are 2 points that I want to make here. First, being in NSCOR per se is associated with the odds of about 3 plus of incurring any expenditures. And in fact, this coefficient translates into about $763. And so the fact that you have had a history of maltreatment as having come into contact with child welfare agencies means that you will incur over 4 years in these 16 states an increased Medicaid mental health psychotropic drug expenditures of about $763. And the other thing that I want to point out to you are these race ethnic factors. So being African American is associated with approximately half the odds of using any mental health service. And this coefficient actually amounts to something like $463 reduction in service utilization. So controlling for all of this, just the fact that you're an African American child means that you're going to incur about $400 of reduced drug expenditures paid for by Medicaid. And that in some sense is deeply worrisome. This is the only NSCOR sample. So this does not have the linked sample. This is just children in the national survey, which actually tells you the CBCL score point that I was making. So a child behavior checklist is actually associated with about this is about $560 or so. And so having a child behavior checklist score that is greater than or equal to 64, which is the clinical cutoff for a child, will actually cost Medicaid agencies about $500 more. So in a sense, we have a range of these instruments on the right-hand side. We have a range of validated psychological tests And we actually I can actually tell you one standard deviation increase in the children's depression inventory is actually associated with a $180 increase in Medicaid expenditures on drugs. And that level of our ability to do risk adjustment, we've never really had in any population, since we are, to the best of our knowledge, the only group that has successfully managed to link Medicaid survey data, Medicaid claims data with national survey data for any population. And so that is what we are really excited about in this work going forward. We can actually figure out, if we can actually advise state Medicaid agencies about what the best rating instrument is, that if you deploy, you can predict a child's Medicaid expenditures. And we're now doing a second paper where we're constructing accelerated panel designs. And so if a child comes in at age 7, I can sort of tell you how much this child is going to cost if you assume that he ages out of the system at age 18. And so we can do this not only in a cross-sectional way or in brief periods of time. We can actually daisy chain utilization and expenditures over the entire childhood developmental cycle practically and say what expenditures are likely to be. So we're really pumped about this. And it turns out that Medicaid policies actually may exacerbate a lot of these race ethnic disparities inadvertently. And so prior authorization policies, in fact, unfortunately, I was on a state Medicaid commission where we actually instituted prior authorization policies for children and child welfare based on extant research. But now we're actually finding that prior authorization policies may actually worsen race ethnic disparities, especially for African American kids, because African American kids seem to have lower rates of utilization of second generation antipsychotics. And we have instituted prior authorization for these second generation antipsychotics. And so if you already have a policy that suppresses second generation antipsychotic use, and you have a population that is already at reduced odds of use of that particular class of drugs, then effectively that policy worsens those races and disparities in use when it comes to SGAs. And so we looked at our data and we scratched our heads, and Lisa Clemens, who's our Medicaid, who's in the state Medicaid program, she's Medicaid's chief behavioral health officer, is a co-investigator on all of my R01s. And so we're in talks about trying to figure out what can we do to make this better? How can we reverse some of the decisions that we've taken in Missouri? And also carve-outs may actually worsen race ethnic disparities. And this is primarily related to the fact that African American kids seem to have lower rates of inpatient use. And I showed you right at the beginning that carve-outs suppress inpatient use. And so as we expand carve-outs in Medicaid managed care, we may actually worsen race ethnic disparities. And so these are examples of how we can directly inform Medicaid policymaking in an effort to ensure that Medicaid policies don't have these sorts of unintended consequences. I'm particularly excited about my summer trip, thanks to Tim's approval of my course called Implementing Public Health Interventions in Developing Countries. We're taking 14 students, MPH students, and some dual students to 3 villages in southern India. This is the main street of, this is the main street of a village called Alakudi. You can see this is a happening little town. And the idea is that we are taking these 14 students there. It's an 8-week-long summer course. In the first 4 weeks, students will attempt to identify a public health challenge faced by residents of these villages, and will understand the determinants of those public health challenges, and will develop a household or a community level intervention that potentially can work in that community. In the next 4 weeks, they will develop an implementation plan and an evaluation plan that village health workers can actually deploy. And part of their final grade is actually going to be determined by these village health worker gradings. Because if they develop a plan that will only work in St. Louis, they've actually failed as public health professionals. And so we constructed these teams, and so we work with the local organization called the IKP Center for Technologies in Public Health. I've been working with them for about a couple of years now. And this is our first joint sort of team taught course that we're offering, and I think it'll be very exciting. It's a rule that all ICTPH personnel go into these villages wearing saris, which is what this lady is wearing, for example. And our students will be wearing saris also. And so we're hoping there are no wardrobe malfunctions in Alaguri.